My name is Mike Antonis. I am a board-certified physician here at OrthoVirginia. I've been in practice over 20 years. I am specially qualified in registered diagnostic medical sonography using an ultrasound, as well as a certified additional qualification in sports medicine. I also have been working with the Washington Commanders for the last 3 years as their team physician. I've also been working with DC United for the last 5 years, previously as their team physician, taking care of everything from musculoskeletal injuries to injections to, as this talk is titled, platelet-rich plasma, including biologics. So I'm going over a lot of information in a short period of time. We have 15 minutes essentially. I wanted to sort of discuss a little bit about PRP, platelet-rich plasma, which is one of these biologics, which is all natural, okay? There's no artificial supplements placed in this. What you can see in this slide is that PRP has been around since the 1970s. They initially used PRP for people with low platelet counts, essentially platelet-rich plasma. And then in the 80s, they used it in cardiovascular surgery, as well as using it in maxillofacial surgery to help with clotting. And then in 1998, really got more in depth with implants and allowing sort of the regeneration of the trabeculae in the jaw so that implants actually lasted longer and better. This is when sort of we saw a little bit more involvement with musculoskeletal purposes. A couple other things that people always ask me is, what are some of the clinical recommendations for PRP? They're listed right here: lateral epicondylitis, patellar tendinopathy, Achilles tendinopathy, rotator cuff, plantar fascia, knee and hip arthritis, ankle arthritis, hand and foot arthritis, UCL injuries, which is pitcher's elbow, ulnar collateral ligament, glute medius tendinopathy, where your muscle attached to your hip, and hamstring injuries. I've treated every single one of these conditions listed on here multiple times and have had a pretty significant success rate. Picture on the right is from last year when we were in, I believe it was Detroit, at one of the away games. So what do we do to get your PRP? We get your PRP by, first off, we do a blood draw. Our system that I use is the M-Site system. We take 50 cc's of your blood, which is equivalent to approximately 1/8 of your, if you would donate blood. So it's a very small amount. Then we send it through a centrifuge. So we spin it right in front of you in a centrifuge. And then we take out the red blood cells through a slight filtering process. Then we take it back into the centrifuge for a second spin so that we can concentrate the platelets and the plasma, which gives us that yellow coat on the top that you see, which is a concentration of plasma and platelets. Now, the magic number that we found in the literature that really works for this is 6,000 to 10,000 times your normal platelet count. The M-Site machines that we use are specifically calibrated for 6,000 to 10,000. Not all systems are created equal. We found the M-Site to be the best system, and that's why I have it at every single one of my offices. It's the same system that I use on the Washington Commanders and on DC United players. It's the same equipment. So one of the things that people always ask me is, well, Mike, when do I start feeling better? PRP is not like a steroid. It is not going to give you automatic relief. It usually takes about 8 to 12 weeks to get the full effect. Does that mean you're not going to experience some relief before 8 to 10 weeks? No. It just means that for its full effect, we generally look at about 8 to 12 weeks. When I see my patients back, usually I'll see them back at about 6 weeks after the therapy. And what I basically do is finding out how they're doing. I'll take a look again at the area that we're looking at, make sure the ultrasound, there's no fluid collections, anything abnormal. And then at this point in time, I really sort of tell people to keep on going, keep on pushing through this. This is going to get better. Generally at 6 weeks, I see minimal improvement. But then once you start getting over to that 8 to 12 week, we see much improvement in the pain reduction as well as sort of functionality. So what I usually tell people, because I have another question I always get asked is, well, I heard that 3 shots are better than 1 shot and 2 shots are better than 1 shot. The literature on that shows that 3 shots are better than 1 shot. But what I found is that, and if you look at that literature closely, if somebody got 100% relief with PRP over those 3 shots, which are generally done a month apart, 85% of that relief was from the first shot, 10% was from the second shot a month later, and then 5% was from the third shot a month later. So to me, it doesn't make sense to spend that type of money on 3 shots when you haven't seen if you are responding appropriately to the first shot, or if PRP is right for you, or if it's going to work for you. So I find that if people want a second, third shot, absolutely. But if you don't get relief from that first shot, if you get 0 relief, the chance of a second or even a third shot giving you substantial relief, pretty small. So to me, if this was my money, which I treat it like it is, I won't do a second shot until, at least 12 weeks out if you've gotten some relief. And I feel that is the appropriate treatment for PRP, where you're not getting 3 shots in a row, 1 month apart. Plus, I'm not going to lie to you, it does hurt when I do the shot. I'm putting fluid into a joint that is not used to having a lot of fluid in it. So depending upon the joint, I'll drain the fluid, especially in the knee. I'll drain all the fluid off first before I put in the platelet-rich plasma. So another sort of consideration that I would tell people is that PRP does not grow cartilage. It does not grow bone. It does not grow tendon. It is an anti-inflammatory. It is an adjunct to conservative therapy. So if you don't do PRP with doing the normal sort of strengthening, modifications, and working on maintaining your healthy weight, it's not going to work. There's no magic growth of anything. If you read on the internet, I'm sure you'll hear the word stem cell thrown out. You'll hear the word orthobiologics, regenerative medicine. Those are non-genuine terms. I have never seen cartilage regrow with the use of PRP, with the use of bone marrow, or with the use of fat cells. I've done all 3 techniques. I've done PRP, I've done bone marrow harvesting from the pelvic bone. I've also done fat harvesting from the back. The fat harvesting as well as the bone marrow are considerably more expensive. They're in the price range of $3,000 each. And I have not seen a significant improvement from those types of processes versus the PRP, which at our cost at OrthoVirginia, we charge $825. So in my mind, if this was my money, which again, that's how I treat it, I would tell you to do multiple PRP shots before you do anything like bone marrow or fat, where they call them mesenchymal cells. It gets around the issue of saying, is it a stem cell, which it's not. This is, obviously a cartoon, obviously a snowman, There's snow, you see the snowflakes coming down. Snowflakes are stem cells for snowman, right? It's not the way it works for orthobiologics and regenerative medicine. As much as I believe and I would want this to work that way, it doesn't. What I usually try to, communicate with people is we need to work on multiple things, not just one shot. If stem cells truly existed and they truly made things markedly better, we wouldn't have things like joint replacement. We wouldn't have things like surgery, because it'd be a simple injection and the cells would grow back. That being said, I am, like I said before, I'm a registered diagnostic medical sonographer. All of my injections are done by ultrasound guidance. So in order for me to do PRP, and when I do a consult for PRP, I do an ultrasound of the area, making sure that I can see all the structures I need to see. I can see if there's fluid or not, what is, the appropriate radiographs or MRIs. I look at them, I sort of explain to you what you can appreciate from the MRI or any of the imaging. So what I am going to show to you is some ultrasound guided procedures that I do specifically for frozen shoulder adhesive capsulitis. I see a lot of frozen shoulder, a lot of adhesive capsulitis. One of the wonderful things about ultrasound is it provides zero radiation, and I'm able to guide my injections into a very confined small space. This allows me to be extremely precise with my injections and allows me to get into areas that you would otherwise be hoping to get into without some guidance. This first picture was a glenohumeral joint injection. You're going to see like a 3-second video, and it will be replayed over and over again. And what you can see is my injection of the fluid going into that glenohumeral joint. What I want you to understand is this is 4 centimeters down, and I'm injecting into a space that is approximately 0.5 centimeter. So guiding that needle in there is not an easy task, but that's part of what PRP is. If you want to get the maximum benefit from it, you need an ultrasound machine to make sure you are in the right spot, you are getting the optimal abilities from the platelets. Next slide. When I do frozen shoulder, if anybody who's had frozen shoulder, I also do an associated nerve block. This is a suprascapular nerve block. So I put fluid into the suprascapular region, which is being circled right now, and you can see the fluid sort of expanding in that area. I go on the side closest to the humerus, which is your upper bone in your arm, and block that nerve so that you can feel a little bit of relief when they start moving you in physical therapy that day. Now, the next slides are going to show you a hydrodilation that I did on this patient as well. So what you're going to notice is right where the pointer is now, you're going to notice the fluid filling up further. So the patient at this time describes that their shoulder is moving, and yes, it is moving. And then it gets further full. People feel pressure at this time. And then sometimes the frozen shoulder is so set that you have to what they call trephinate it. So that pistoning that you see up and down is actually my needle on the posterior capsule, breaking up that scar tissue that's sort of inhibiting the person from moving their shoulder. So this is one of the outcomes that you can see with a hydrodilation. Now I'm going to show you another outcome that you can see with a hydrodilation. Again, this is a different patient. I'm going to do the suprascapular nerve block right there. You can see it getting larger through there, and people will feel a little numbness into your fingertips. And then the next slide is going to show you a rupture of the joint. So as you can see, you see how the shoulder is getting further and further away, and then there's a rupture, and then there's a release, and that releases all of that adhesions within that frozen shoulder, and patients do remarkably well with this procedure rather than a surgical procedure to release these adhesions. So at this time, let me see if I can't take any questions. These are obviously some pictures when I was with DC United over the last 5 years.
Thank you so much. We do have questions coming in. So one of the questions is, I've had a shoulder replacement on one shoulder. Will getting PRP on the other shoulder delay surgery?
That's a fantastic question. And the answer is, the one great thing about PRP is that it will never cause any harm because it's your own cells. There's nothing artificial about it. I injected multiple places around your shoulder. I inject into the front of the shoulder, I inject into the side of the shoulder, and I inject into the back. So I spread all of those cells, platelets, throughout the entire shoulder process. Is it going to guarantee you're going to not get a shoulder replacement? No. But as one of my slides shows, it can delay surgery and it can delay that inflammation. It is an anti-inflammatory, which is what I want you to gather from PRP and any of these stem cell products, is they're anti-inflammatory. They don't regrow anything. But being an anti-inflammatory, it decreases, change that degenerative process that happens in the shoulder that sort of caused you to have the shoulder replacement on the one side. I can almost guarantee you have some of the stuff on the other side. So yes, it can help with the inflammation, and it doesn't have the bad side effects of a steroid shot, which cortisone can break down the cartilage, it can break down the tendons, whereas PRP may not work as quickly as steroids, but it has the anti-inflammatory effect, and it also has a decreasing the inflammation throughout that entire shoulder as I do it under ultrasound to make sure it goes in the correct place.
Thank you. Does insurance cover PRP? What about Medicare? So
no insurance covers PRP. We don't accept insurance coverage for PRP. It's considered by insurance companies to be investigational, even though we've been doing it since the 1970s, as I showed you on the slide. Unfortunately, I personally think that insurance companies are trying to figure a way to charge it for your own blood, because there's nothing else in there.
Thank you. A couple of people have asked if it's effective if someone has a low platelet count themselves.
So generally, what you're doing is you're concentrating the platelets. So whatever your normal platelet count is, our machines, you multiply it by 6 or 10. I have a low platelet count personally, so I've had PRP done on me. I'm on the lower end. I'm at like 100,000 platelets. Normals between 150 versus 400,000. So the concentration of platelets is very important. You want to get close to that million mark. But if you don't get to that mark, it's not that it's not going to help you. It may not be optimal.
Thank you. How long do you need to have downtime after you have a PRP injection?
So my rule of thumb, and I give anybody that I'm doing PRP in my sort of basis of up to 12 weeks, what I expect you and what marks you should be at. My general rule of thumb though, 2 days, 2 weeks, 2 months. 2 days, I tell you, you're just going to want to do normal activities. I want you, if it's your shoulder, I want you to do normal range of motion, no lifting. If it's your knee, I do want you to do normal range of motion of the knee, no deciding to go for a run, no deciding to go for a walk. And then over 2 weeks, I have you do normal daily activities. And then after that 2 weeks you start doing exercises controlled, and then by 2 months is usually when the maximum effect of PRP is going to occur. So now, that being said, I also do this on professional athletes. So I will do a PRP on a professional athlete on Monday and they're playing Sunday. So it's not that you won't get some effect, but the optimal effect is not felt for 8 to 12 weeks.
Thank you. We have a lot of people asking if it can be used for back problems. I know you said it can be done for knee and hip arthritis, but what about back pain?
So back pain is a little bit beyond what I do as far as PRP, because you need specialized equipment to inject the PRP into the back. The ultrasound that I use and is sort of the equipment that I've spent 20 years learning and mastering. It's not something I just picked up. It is a little bit more radiographic, so you need somebody who does radiology guided injections to do PRP into the back and into the tendons, the discs, or into the facet joints. The ultrasound just doesn't get deep enough, and I'm not able to perform those procedures.
Thank you. Is anything added to your plasma before it's injected?
So that's a great question. I'm sure the person who asked that is asking about activation. So if you read the literature, some people add a little bit of calcium for activation. Some people put a little bit of dextrose to sort of activate it. I have not found that activation of anything foreign makes the procedure any better. The reason I still do PRP is because it's all natural. I don't want to change our natural body's healing process and the anti-inflammatory effect of what we are using naturally, and then add something artificial to supposedly activate the platelets and the plasma. In my mind, you are using something all natural for a reason. Why add something at the very last step that is formulated or done in a laboratory?
Thank you. Can you go back to talking about PRP for arthritis for a minute? We have several people asking if it can be used for arthritic wrists or arthritic ankles, if it's appropriate if you have an osteoarthritis diagnosis, including bone-on-bone arthritis.
So the answer is, what PRP does with arthritic joints, wrists, I've done lots of wrists, ankles, hands. I have quite a few patients with rheumatoid arthritis for injections in their thumb and wrists. It does not, unfortunately, change the bone structure, but what it does is the anti-inflammatory effect of the PRP decreases sort of the inflammatory process that's occurring in that joint, whether it be your thumb joint, whether it be your knee, whether it be your hip, whether it be your ankle. It changes that milieu of bad degenerative conditions that just sort of over and over just sort of start deteriorating. It changes that milieu to a anti-inflammatory, decreasing inflammation, decreasing and changing that entire environment. So it gives you some relief of the pain. Is it a permanent thing? No. Does it provide relief over a specific period of time? The answer is yes. I have patients who come to see me from all over the country for repeat injections every 6 months because it's postponing their surgery and it gives them significant relief. And I have some that come every year. It's always everybody's individualized in that reason, in that question.
Thank you. If cortisone shots haven't helped, should somebody try PRP before going to joint replacement surgery?
So that's a great question. And what ends up happening is cortisone shots at the beginning work fantastic. So they give you extended relief, especially in the hip, the knee, the shoulder. A lot of people will get relief over months and months and months. But then as you get more and more cortisone shots, the relief becomes less and less and less. And that's part of, unfortunately, the arthritic process. But PRP can be sort of another tool in sort of our toolbox to decrease the inflammation. I have a lot of patients where what I'll do is I'll do PRP every 6 months, and I'll do a cortisone shot every 6 months as well, and I'll alternate them. Or something is put into a joint 6 months apart. And what it does, some people get more relief from the PRP, some people get more relief, a little more relief with the steroid, but doing something sort of almost like year round can sort of stabilize them to give them a couple more years before eventual replacement of the joint, or you finally got it strong enough that you no longer have that inflammatory process going on.
Thank you. Are there age restrictions on PRP? So could a teenage athlete have it, or what about somebody in their 80s?
So either one, there's no age restriction. Obviously, when it's a younger patient, PRP actually works really well because they have great tissue, and it is much better for their system than a cortisone injection, which has obviously changes, especially depending upon the age. It does require a little bit of talking through, because like I said, it does hurt when I do the injections. So it is a little bit more painful than a steroid shot, where a steroid shot's real quick. PRP takes a little bit more time. You want to get into the right spot. You want to get it into multiple spots depending upon what the injury is. And then as far as on the opposite age of spectrum, I've seen it work extremely well into individuals well into their 80s and 90s. That sort of decreases that inflammation. You still have functional platelets all the way, because your bone marrow regenerates the platelets, your blood cells, your spleen takes it out of your system. So it's a constant regeneration of the platelets and red blood cells.
Thank you. Are there any contraindications or side effects that people need to be aware of?
So one of the contraindications to PRP is active cancer. Obviously, if anyone has active cancer, or a cancer that is metastasized, or a blood-based cancer that is actively undergoing treatment, that's one of those ones you've got to be extremely careful with, and pretty much a contraindication in my mind. You don't want to inject blood if somebody has a active, cancer into a joint, and possibly place that joint at risk for spread. And then obviously bleeding problems. If someone's got platelet counts in the 10,000 mark, which you're worried about, spontaneous bleeding in itself, that is not something you really want to resort to. And as far as, risk of infection, very low, because there's, again, no evidence of any changes to the PRP, meaning that I don't put any activation agents in it. I use your own blood, so there's nothing artificial going back into you. I use sterile technique to make sure that we are only putting in preservative-free platelets back into the joints.
All right. Thank you so much for all of your information today. That is all of the questions that we have time for right now. We didn't have a chance to answer your question live. We will answer it in the comments later. Would you like to close?
I just wanted to thank you for giving me this opportunity to talk to you guys today. And, Obviously, PRP is something I'm passionate about, and there's a lot of places out there that give you misinformation. Be careful. I've seen a lot of people getting taken advantage of by promises that cannot be kept. Follow the science, and if it's too good to be true, it probably is.